Hi, good morning to all. Today we are going to learn about lobar anatomy. It's anatomy of the lung lobes. A fingertip knowledge of lobar and segmental anatomy is essential for understanding patterns of lung collapse and patterns of lung disease. The patient aspirated a pin. In what lobe is it located? So this is the close-up view. The answer is in the last slide. So the inner thoracic wall is lined by the parietal pleura, whereas each lobe is surrounded by the visceral pleura. The space between the lobes of the lung where the visceral pleural surfaces touch is called as the interlobar fissure or septum. Because the visceral pleura is less than 1 mm thick, the X-ray beam must strike it parallel to its surface if it is to be visible on the radiograph. Here the X-ray beam is parallel to the fissure or septum. The fissure will be visible on the radiograph. If any plane is perpendicular or oblique to the X-ray beam, it will not be visible on radiograph. So this figure shows that in the left lung, the upper lobe is separated from the lower lobe by the major fissure. The major fissure is parallel to the X-ray beam only in the lateral projection. So this fissure will not be visible on the frontal PA projection. The major fissure runs obliquely downward from approximately the level of the fifth thoracic vertebra to the diaphragm, where it ends at a point just short of the anterior chest wall. So this is the close-up view of the major fissure. So what's the position of the oblique fissure? It's a curved line on the thoracic wall that begins roughly at the spinous process of the T4 vertebra 4 level of the spine. It crosses the fifth intercostal space laterally and then follows the contour of the sixth rib anteriorly. So this oblique fissure crosses the fifth intercostal space laterally and then follows the contour of the sixth rib anteriorly. Horizontal fissure follows the fourth intercostal space from the sternum until it meets the oblique fissure as it crosses the fifth rib. So this is the lateral aspect of the right lung. One is apex of the lung. Two, upper lobes of right lung. 3, horizontal fissure of the right lung. 4, oblique fissure of the right lung. 5, middle lobe of right lung. 6, lower lobe of right lung. And 7 is inferior border of right lung. The lateral aspect of the left lung. 1 is apex of left lung. 8, upper lobe of left lung. 9, impressions of ribs. 10, oblique fissure of left lung. 11, lower lobe of left lung. And 7, inferior border of left lung. So the major fissure normally appears as a thin white line. So it's a 2 layers of visceral pleura surrounded by air. If a lobe is consolidated, the fissure appears as an edge that delineates that lobe. In this X-ray, the lower fissure looks like a line, but the upper fissure is an edge because the upper lobe is consolidated or airless, but the lower lobe is aerated. If pleural fluid enters a fissure, the fissure thickens. Here you can note the thick major fissure and a normal minor fissure. In an erect patient, the minor fissure is usually horizontal. It is parallel to the floor So it will be easily visible on the radiograph. So minor fissure is usually visible in both views. So this is the close-up view of the minor fissure and major fissure. On the lateral film, the minor fissure, it's a horizontal fissure, starts posteriorly at the right major fissure and it ends on the anterior chest wall. The junction of the minor fissure and major fissure often helps to distinguish the right from the left major fissure on the lateral view. So in the lateral view, sometimes it's difficult to differentiate the two major fissures. So this is a simple method is there. So the left major fissure ends on the left diaphragm. The left diaphragm is usually lower and it has a stomach bubble immediately beneath it, and it is not visible anteriorly because the bottom of the heart rests on it. So now how to identify the fissures on the X-ray. So this is minor fissure. It's a horizontal fissure. 2 is right major fissure. 3 is left major fissure. In the lateral view, 1 is minor fissure, 2 right major fissure, and 3 is left major fissure. Then identify the lobes. So the 1 and 2 are upper lobes, 3 and 5 are right lower and middle lobe, 4 and 6 are lingula and left lower lobe. In the lateral view, 1 and 2 are upper lobes, 3 and 4 are lower lobes, 5 is right middle lobe, 6 lingula, 7 is left diaphragm. On the frontal view, the superior portions of the lower lobes rise to the level of the aortic arch. So this is the consolidation of the right middle lobe. This is consolidation of the right middle lobe. The superior margin of the right middle lobe is the minor fissure and the posterior margin is the major fissure. This X-ray shows consolidation right upper lobe. This left upper lobe consolidation. So now coming to the question which I asked in the first slide. A patient aspirated a pin in what lobe is it located? So it's very simple. It's the right lower lobe. So take home message. Train yourself to look for the fissures on every chest image. They are not visible on every patient. They help to localize disease in the lung. As we shall see in further classes, displacement of the fissures is the most reliable sign of lobar collapse. Thank you.